is a huge honor for me today to be interviewing Geoffrey Hall all the way from Melbourne, Australia. I just saw your lecture. What was it? 2 or 3 months ago, and I saw you in a lecture. We both lectured actually in Melbourne, Sydney, and Brisbane. Was that the three cities? And I was blown away by your presentation, everything about you. Thank you so much for joining me today, because when I was listening, I said, oh my God, the Americans got to hear this. So today you're talking to mostly Americans, thousands of them, as they're commuting to work. So I want you to start with, are you a general dentist or are you an orthodontist?
I'm actually an orthodontist. I actually did my orthodontic training in America at the University of Pennsylvania back in 1990. To be honest, I would say I'm 75% American.
So do the Australians recognize a U.S. dental school? Is it accredited back home, or did you have to go to ortho school back in Australia?
No. It was the orthodontic training was accredited here in Australia, but because I was a dentist first in Australia, that's the degree that they utilise, similar to your board registrations in America.
So yeah, because I wonder because usually Americans they don't accept licenses from other countries.
Yes.
And I always think those are rackets to support the teachers unions, especially when they're from countries like Australia, Germany, Japan, Korea, countries that have dental schools that are just as good or better than America. So I want to get to the right to the point. So you're an orthodontist.
I'm an orthodontist, yes.
And do general dentists? This is how I could sum up the 9 specialties. Most of the time when you deal with an oral surgeon, he or she don't care what you do. You know, he figures you're going to pull the easy ones. You'll send the impacted wisdoms you don't want. They don't even care. You talk to an endodontist, they'll show you everything they know. They assume you're going to do the incisors, and you may do molars. You might not do reaching. It seems like with all the specialties, they're just there to help you. They want to show you everything they know, all that kind of stuff. And then there's the orthodontist.
Exactly.
And
right.
It's just like this is a closed society. You should not do. I mean, they literally say to you, if you want to learn ortho, then go to ortho school. And you're like, well, what about minor tooth movements, 6-month smiles, power procs, Invisalign, whatever? And it's just like it's a closed society. Is that a fair assessment or not? Am I reading this wrong, or do you agree that that's how it is?
I think you're actually probably light on in your assessment. I think they're even more so than how you've described it.
Well, describe it.
Well, it's exactly that. I find it quite bizarre that a dentist can put in an implant, right near the sinus of an upper right 6, but cannot put a bracket on a tooth, with composite resin. It defies any logic.
Yeah, because one involves bleeding, suturing, scaling, bone grafting, surgery, anesthetic. The other one involves glue and rubber bands.
Yes, and not necessarily rubber bands, just glue that they use every day.
Yeah, it's a weird deal. And what upsets me about it, where it becomes personal, coming from Kansas, where my whole pedigree is from like Parsons, these small towns, is these dental schools don't teach these kids ortho, and then half of them go back to rural communities where there's no orthodontist.
Precisely, and that's not doing a service to any patient.
And those rural taxpayers picked up the bill of all these public dental schools. Yep. And then they send them back doctors that aren't educated to you need to be a full, well-rounded doctor in a small town.
Well, and that's exactly right. And to be honest, even in bigger towns today, you need to be more well-rounded. Even if you're not going to do it, you need to be able to diagnose it. You need to be able to treatment plan with the other specialists. So the more knowledge you have, the better dentist you're going to be.
Absolutely. And all of my friends, myself included, that learned how to do ortho, when you learn how to do ortho, you learn more about occlusion and TMJ, because when you're listening to these TMJ people who have never done an ortho case, you're just listening to them like, dude, have you not done one ortho case? Because everything you just said, if you just did one ortho case, you wouldn't believe any of this stuff. And it was Carl Misch who said, I became a great implantologist because first I became an expert in removable dentures. And I got into implants because when these guys were doing overdentures, they were saying the titanium was too weak and was snapping. And I was looking at the denture like, Well, the denture is so bad, and you were so wrong on the bite. I mean, you put a F denture on these implants, and then when they snap, you said it was the implants. So he said, if you don't know how to build a denture correctly, you don't know how to build an implant over denture correctly.
And that's exactly right. And and orthodontics is fundamental. I think the biggest problem that we've had is that there is a small percentage of difficult patients, and we're throwing the baby out with the bathwater, because these orthodontists say, well, it's all to do with diagnosis, but 90%, probably 90% of patients that come in are quite straightforward patients, and that can be treated by just about anybody. And the problem I think we have in orthodontics is we've worked on the basis of swings and roundabouts. We charge the same fee whether it's a difficult case or an easy case. So the orthodontists are making their money out of the easy cases. They actually don't do that well with the difficult cases. And they need to be more highly trained in those difficult cases, because that's what they should be getting referred.
And that's the way all specialists are. Like, I'll pull out the easy tooth of the gum disease, and the oral surgeon will pull out the impacted wisdom tooth. I'll do the straight canal. He can do the retreat, whatever. So that's what it is, all those specialties. But I'll tell you another thing on Dental Town.
And he should be charging a premium for that. Yeah.
We put up 350 online course on Dental Town, and there's none on ortho, because the orthodontists that they go, Howard, if I put up a course teaching ortho to general dentists, I would be an outcast of my local study class. I'm not going to live my life that way. I'm not going to you will never speak at an ortho meeting. You will never nobody will like you. And so I always knew back when I started Dental Town in 98, if I was ever going to get an ortho curriculum, I'd have to look outside of the United States. I'd have to look for a Canadian, an Australian, a British person. And I'm hoping you deliver that someday. On the internet, there's not one single online curriculum to teach orthodontics from A to Z.
Really? Mm-hmm. Well, we are looking into that at the moment. But it's funny you say that, because about being an outcast, because I would classify myself as an outcast here in Australia for exactly the same reason. It's no different in Australia how I'm perceived, because I'm teaching orthodontics to general dentists. They don't like it. They're threatened.
So do you feel evil?
No, I come to the philosophy, people are talking about me, I must be doing something right.
Absolutely. Why do general dentists need to learn orthodontics?
Well, if America is anything like Australia, which I'm sure it is, because we're 10 years, I think we're 10 years behind America in just about everything. I think there's a couple of reasons. Firstly, the economic times are such there are more dentists graduating. The times are much tougher, so they need to have orthodontic part of their practice from a financial point of view. Also, most patients today are coming in for cosmetic work. They don't come in to say, please give me an endo on an upper right 6. They're coming in because they want their teeth straight and white. So you've got to be able to offer them what they want if you want to stay in business. And the third part, which I find quite amusing, is I think most of us got into dentistry because we're a little bit more intelligent than the average person. And yet when we get to dental school, they just teach you to hold a burr and to drill and to stop thinking about what you're doing. It becomes very mechanical. And orthodontics, you have to do a little bit of thinking, and it's actually fun again to start to think. And a lot of people, if they're anything like myself, you get a little bit bored with general dentistry after a few years, and you need to find other avenues. And the people who I've trained in orthodontics say orthodontics, it's been the best thing they've ever done.
Well, I believe, I listened to a lecture by a neuroanatomist out of Italy, and he said that the body of the literature shows that there's no difference if they study 100 ants, 100 dolphins, 100 chimpanzees, 100 humans. All the brains are the same across species. That they can't find anything that says, oh, this brain's smarter, this brain's less. But what you become good at is if you're interested in something. So like someone who's a violinist, well, hell, she played violin 4 hours a day from age 5 to 25. I don't want to do that. So it doesn't mean she's a musical genius and I'm an idiot. I just don't want to play the violin. And what I like most about ortho and Invisalign and people who join the AACD is that, if you hate endo, you can't afford to do endo because if you do root canals and hate it the whole time for the money, if you do things you don't like to do for money, it'll always come back and bite you in depression, substance abuse, throwing instruments, selling your practice. And so many dentists, they in dentistry that they didn't like placing implants, or they didn't like molar endo, they didn't like blood or guts, but they loved cosmetics, they loved ortho, they loved minor too, man. And what you got to do is you got to go play every day and be and so many. My buddy Joyce up the street, who's the first female dentist president of the American Academy of Cosmetic Dentistry. My God, she doesn't need another dollar for anything in the world. She's got more money than anyone, and she just loves it. She just goes there every day doing these big cosmetic makeovers on women who cry when they get it done. And I mean, it's just crazy that she loves it. She'll do it till she's 103.
Yeah, and that's how it should be. If you're gonna be, whatever you do in life, you've got to enjoy it. And I'll be honest, I did not enjoy dentistry as a dentist, but I love orthodontics.
Okay, I want to give you a very good. I'm the owner of Orthotown too. I have Dental Town and Orthotown. Now I have to go on Orthotown because I'm not an orthodontist. Orthodontic company that only sell ortho products. They're not allowed to go on either. But one thing they tell me that I agree with. They say, when you're learning how to do Invisalign or 6-month smiles or Power Procs, whatever, if you don't know how to do complex ortho, then when you're doing these simple ortho cases, a lot of times you don't even know what you don't know. So so I guess the question is this. This is the specific question. Can a general dentist do 6-month smiles, Power Procs, these short-term ortho courses in Invisalign without understanding how to do full complex orthodontics?
Absolutely. What they have to understand, though, is what are the complex cases. But they don't have to understand how to do the complex cases. They just have to be mindful of what is a complex case, and that's very easy to teach them. But even more so,
can you teach them right now? Talking to them in their car. 95% of my podcasters are just listening. It's only 5% are watching on video.
Okay, I could teach them. Yes, I could teach them doing a podcast.
Do you want to do that, or do you want to build an online CE course for Dental Town sometime? I
think something visual is better. So
I do too.
I would prefer to do the online course.
Most people only listen to this on iTunes because they saw my face one time and they said that with my face, I do not have a face for YouTube or television. They said you only have a face for radio or our podcast. But can you talk about, because what I'm thinking of she's driving to work right now. How hard is it to figure out because she's thinking, I don't want to get into this if I'm going to screw up a big case. Can you kind of go over talking to her in her ears about how hard is it to stay out of trouble? That's the question. How hard is it to stay out of trouble?
I think there are 2 points to it. One is I can train them to stay out of trouble. That's not an issue at all. But I think the problem with all that is that I think there has to be a system in place where they can actually send the case and somebody just says yes or no to that case. By the web, via a secure portal, so they can actually get treatment assessments done so they're 100% confident that they will be out of trouble. But for example, if your viewers want to know what would be a difficult case, for example, if you're talking, it's what patients can't accept. Patients can't accept an anterior open bite when they're finished. They can't chew. Patients can't accept a reverse cross bite, being a class 3 patient. So the 2 main categories of patients that I would be telling them not to treat are patients who have got minimal overbites and patients who are class 3 patients.
Okay, explain what a class 1, 2, and 3 patient is.
Okay.
There's 7,000 people listening. There's someone might not remember that.
Okay, a class 1 is basically a patient who has an ideal overbite overjet, and basically teeth fit together like a jigsaw puzzle. So to have an ideal overbite overjet, which is say a 3mm overbite, 1mm overjet, you've got to have what we call a class 1 canine relationship and a class 1 molar. And a class 1 canine relationship is where the tip of the upper canine sits between the groove of the lower canine and the lower first premolar. And a class 1 molar relationship is where the tip of the mesiobuccal cusp sits on the buccal groove of the lower first molar. A class 2 patient would then have more overjet. So in other words, with a class 2 patient, the upper arch is forwards of that ideal class 1 position. So the mesiobuccal cusp of the upper first molar would sit forwards to the buccal groove of the lower molar. And the upper canine, which should normally sit between the lower canine and the lower first premolar, would sit forward of that position. And that would be a class 2. And by definition, they must be left with overjet. And the amount of overjet they will be left with is very easy to figure out, because all you need to do is measure in millimetres the canine relationship. If the canine relationship is a 3 millimetre class 2 on both sides, they have to be left with 3 millimetres of overjet as the teeth are straight. And then the worst scenario is the patient who is a class 3, where the lower arch is forwards of that class 1 position, because then they're going to end up with an anterior crossbite or a reverse overjet, and patients won't tolerate that.
Interesting. Now, do Australians, are they familiar with Jay Leno? Would Jay Leno be the most famous class 3?
Yes, we know Jay Leno, yes.
And would that be the most famous class 3 that comes to your mind? It's when you have a big lower jaw that protrudes.
Yes. Yeah, he would probably be the one that would come straight to my mind.
And who would be the most famous class 2 overjet, where you don't have a chin, when you smile, your liver shows?
That's a very good question. I actually haven't thought of that one. I haven't thought of that. But there'll be plenty of them.
Okay. So explain. Okay. So now you were also showing me, is it your system, the Precision Digital Indirect Bonding System? Is that yours?
Yes, it is.
And what I thought was amazing about that is you were having the lab set all the brackets in a tray indirectly, and then you were cementing them all at one time. And what is that system? What do you call that system?
Well, we call that
Smilefast.
That's our Smilefast system. Yes.
Okay.
Yeah.
Well, explain what's okay. So your website is smilefast.com. Now, do Americans have to, after the .com, put .au, or if they go to smilefast.com, does it go to yours?
No, I think they've got to put .com.au, but that will be changed soon.
Okay. So if you go to smilefast.com.au, the .au is for Australia, they're going to go to your website. How long's that website been there? How long Smilefast? Tell us the Smilefast story.
Okay. You mentioned other techniques such as 6-month braces, 6-month smiles, etc. So yeah, the whole idea of short-term orthodontics has been around for a fair few years, and I think Invisalign has really driven this cosmetic orthodontic market.
And Invisalign was invented by a man in Pakistan, right?
Well, he's American. He was American, but from Pakistan origin. Yes.
And now he lives in Dallas, and it was kind of like a Steve Jobs story where they went public and then they got rid of him, right?
That's exactly right. His name was Zia Christie. Yes.
Zia what?
Zia Christie.
I want to podcast that guy. Do you know him well?
I do know him. Yes, he's on my Facebook.
Tell him I want to podcast him. But so then it was like Steve Jobs. So he built this big Invisalign, had the patents, then they got rid of him. And now the patents are about expired. And yes. He started a new company. What's his new company?
He started a new company about 10 years ago, which I think was called Clear Smiles, if I'm not mistaken. But Invisalign closed him down.
Okay.
But now there's another company out there called ClearCorrect, which I don't know whether Zia has an interest in there or not. But knowing Zia, he probably does behind the scenes. Okay. Mm-hmm. And Invisalign has not been able to close ClearCorrect down, as it turns out.
But it doesn't matter, because don't all those patents expire real soon?
Well, there's a yes and no to that. The main patent expires in about 2 years, but they've got so many other patents with regards to attachments, etc. I don't think anybody really knows which patents are still going to keep going on and on. The original will expire in a year or two.
And what is Smilefast? Is that like a short-term ortho, Invisalign, ClearCorrect? What is that?
It's more of a short-term ortho. Okay, and I think what you've got to realise, how I'm coming from now a little bit with an orthodontic hat on, from an orthodontist point of view, because what I want is I want to train doctors with sound orthodontic principles. Okay, so all of these other systems have been done, you know, with general dentists who know a bit about orthodontics, but they're not really sound biomechanical systems. They've been taught something by somebody who's been taught something. So I brought Smilefast in, which is coming from an orthodontist. What's really unique about us is, I think one of the things that orthodontists will tell you is the most difficult thing to do in orthodontics is position brackets correctly. That's the hard part to do in orthodontics.
But why is that the hard part when the assistant does it every time?
Well, they should. They should.
Come on. You know, Geoffrey, that nobody cements a bracket. The assistant does that.
Well, in Australia, that's one thing we have to do. But I know in America, that's a whole different thing.
Shoot, I'll never forget a Friday. I wanted to return something to my orthodontist. The whole place was packed. They're like, oh, don't say anything. Last night he went to the cabin. I mean, they're not even in there on Fridays. But anyway, continue.
Yeah, well, yeah. And I'm not going to say that's the right way to do it. But, yeah, well, when I was trained in Philadelphia, it was actually very interesting because I was trained by Ron Roth and a guy called Norm Setlin. And so these were some of the real, and the guy who invented the bracket, the Siamese twin bracket, a guy called Barney Swain. And so these were like the gurus. And I was the first Australian ever to train in Philadelphia. So they took me out for dinner, these 5 orthodontists, and they said to me, and they were having this discussion between themselves, and they said, has there ever been a case where you haven't had to re-bracket a tooth to get the perfect result? And these 5 orthodontists, who probably would have been the best 5 orthodontists the world's ever seen, said there's never been a case. And that's all I do in my practice all day, every day to get perfection, is to re-bracket teeth. So then I thought, we're now in the digital world, and the hardest thing to try and teach a general dentist without a lot of experience is how to put brackets on. So that's where we set up this digital indirect bonding system. So now we can place the brackets entirely, in just about the perfect position, within reason, because there are some teeth that are so rotated you just can't get the brackets on perfectly anyway. But within reason, we can get the brackets on perfectly. Then that gets transferred to this indirect bonding tray. So the chairside time for a doctor to get your brackets on perfectly, which is the key to aligning teeth, is about 2 minutes for the doctor's chairside time. So now and through this digital technique that we've got, it's now like an Invisalign clean check. You can show the patient, you can do the measurements, you've got a whole visual representation of what it's anticipated to look like, which no other system has. And I think that's really...
Okay, let's slow down and talk specifics. So what do they need to do? They need to take a pano and a ceph and study models, and then they mail that to you physically, a pano, ceph, and study models?
Yeah, basically, yes. Yeah.
And does your company trace the ceph?
Well, no, let's go back a stage. We have a portal. We actually have an online portal, so they don't have to mail any X-rays. They just load all the case on our online portal. The photos, they can load up the X-rays, any comments they want. The only thing they need to send to us is the impressions, and that's all they need to send.
Now, are you going to eventually have the oral scanner? I know that, didn't Invisalign buy an oral scanner?
Well, they bought the Ortho CAD scanner. Any scanner, if they've got a scanner that can get STL files, which is just about every scanner. Carestream's got one now. 3Shape's got one. They could load those files straight onto the portal.
And then this is all based in out of Melbourne, yes. Australia?
Yep.
Okay, so then you would get it, and you got the scanned, so they can mail you hard models, or they could send you an STL file, and then they upload the, what do you need, a pano and a ceph?
Yeah.
And photos?
And definitely photos.
And definitely photos. And then you guys pour up the model, go on.
So we pour up the model. If they give us a model, we produce the STL file then, because we do the scanning if they don't have a scanner. Then we provide the digital setup with the bracket placement. We send it to the doctor with a 3D viewer so they can manipulate it all, and then they can say that they can modify it. And as soon as they press the approve button, the indirect bonding trays are made with the brackets in that exact position.
So then you get the patient back and go through the exact bonding stage of how you band these brackets on.
Well, this is really difficult. This is why dentists can't do it, okay? Because you've got to etch the teeth, you've got to then put some bond on the teeth, and then you put some composite on the back of the brackets which are in the transfer tray, and then you've got to hold that transfer tray in for 2 minutes.
Do you have to put any resin on those indirect brackets?
Yeah, so you put a flowable composite resin on.
Oh, just a flowable composite, but no bonding agent. No resin.
You do put a bonding agent on about 20 minutes prior, just solo, whatever it be, just to wet that composite to allow the new composite to bond.
And what resin cement system do you recommend bonding with?
In our practice, we use a Kerr product called Maxim.
Kerr products Maxim.
Maxim Elite. It's a dual cured flowable composite that you use for luting inlays.
Nice. And spell that Max what?
Maxicem. Maxicem.
So Kerr, which is owned by Cybron, which is owned by Danaher, right?
Yep.
Okay. That would be phylum, genus, species. Okay. So, and how long does that take to set that on there?
Well, because it's dual cured, it'll set in about 5 minutes as a chemical cure, but we also use the light to get it to set very quickly. So in 5 minutes, it's all set. You take the trays off, and the brackets are now bonded to the teeth.
And then you're going to start with what wire? How many wire systems is this going to be?
We try to keep this very simple because we're doing simple orthodontic alignment. So it's usually 3 wires: an 014 night eye, 016 night eye.
014 night eye, and then the second wire will be a 016?
Yes, and then the third wire will be an 018 night eye.
018. So you're staying always with round.
But basically, it's very rare that we would be using rectangular wire unless there are specific reasons to.
Okay, so for my viewers, in America, the 10,000 orthodontists probably do 90% of all the ortho. So these guys listening to you, I want you to explain what is the difference between night eye and stainless steel, and then secondly, I want you to explain the difference between using a round wire and a rectangular wire. Okay.
Firstly, in the old days, if you go back to the old days of orthodontics, and you remember the old orthodontists would show you these wires with all these big loops in the wires and everything else, and no different to when you were at dental school and when you made one of those URAs, those removable appliances to push an upper right lateral out of crossbite. What you would do is you would actually add more coil into it, into the stainless steel wire. And the reason you have more coil in it is to increase the flexibility of the wire. So in the old days, you couldn't get these thick stainless steel wires engaged into brackets because the whole way of how orthodontics works, you put your brackets on, and whatever wire you put in there, the teeth are going to move to the shape of that wire. The brackets are just a handle on the tooth, and the teeth are going to move to the shape of that wire. So in the old days, we had stainless steel wire, which was too stiff. So you had to be a really good orthodontist to be able to bend wires with all these loops to give it the flexibility to engage into these brackets. In the 1970s, night eye came along because of the space program, NASA, and you guys use night eye all the time now in endodontics. And night eye is what we call a shape-activated wire. It always wants to return back to its original shape. So here we are, when we get it out of the box, it's a flat shape. It's a straight, round, flat shape. So if we engage that into a bracket, that tooth will now want to move into its flat shape. It's just made orthodontics so easy that the key to it is putting the brackets on in the correct position. So the wire will then drive the teeth into the correct shape. Okay, and that's night eye wire. And they come in sizes, so you do it in a very gentle progressive force. And the nice thing about night eye is, we all remember from dental school days that that orthodontic movement is a slow, continuous force, is the best way to move teeth. Now, NiTi, whether you deflect a NiTi wire by 0.5 of a millimetre or you have to deflect it to get into a canine by 5 millimetres, it's actually the same force level. So you're getting the same consistent force. If you did that with a stainless steel wire, the force would triple in force, which then means the forces are too high and you get what we call undermining resorption and the teeth don't move and you get more unwanted side effects. So NiTi has revolutionised orthodontics. As I understand, it's revolutionised endodontic treatment as well. The question that you have with round and rectangular wires, rectangular wires, what will engage a bracket to get torque. And by torque, what we mean, it actually moves the root of the teeth. Okay. Now, 90% of cases don't require root movement. Invisalign is very ineffective in moving roots of teeth because they're only pushing on crowns of teeth. So it's not. Rectangular wire is very overdone in orthodontics. We get taught as an orthodontist, you've got to put rectangular wire in. You've got to put rectangular wire in. And in fact, when you talk to some of the best people around, they will tell you that the more times you put rectangular wire in, the more the case gets out of control because you end up with torque in different places and the occlusion gets mucked up. So you don't need to, there are only specific situations where you do need torque control. For example, if you've got a lateral incisor which is so pushed in palatally that the root is still palatal. So 90% of cases that we treat, you don't really, they look fantastic just with round wire. But we do teach people when to use rectangular wire, but it's not as often as what people would think.
You know, one of the reasons back in the day when I got out of school 30 years ago, you know why back in the day a lot of the general dentists started doing some orthodontics is because 30 years ago, if you sent any case to an orthodontist, 9 times out of 10, the diagnosis was pull the first 4 bicuspids and then do the ortho. And what it seemed like to everybody is that they would pull those 4 bicuspids, they would put in the round wire, level and align everything, and it'd look almost done in 6 months. And then they'd spend the next year and a half trying to close back the 5 millimeter spaces where they had done these extractions. And,
Exactly.
what drove me nuts about it is they would pull 4 bicuspids, and I would think, well, you know, they had MOD amalgams on their bicuspids. They had crowns on their first molar. If you just would have came to me and said, make 5 millimeter space, I could have redone those old amalgams with composites with open contacts. I could have slenderized a little in between the teeth. I could have taken off those big fat bulbous crowns and put on crowns that had, that were smaller. I could have made you your 5 millimeters of space while redoing a bunch of old amalgams and crowns and crap that needed to be redone anyway. And it just seemed like everything was just one cookie cutter approach, pull 4 buys. Now, if someone comes to you at 2015 and says, never ever pull 4 buys, now you're talking to an extremist. I mean, the truth is always 50 shades of gray. There's absolutely times when you need to pull 4 first bicuspids. But there does need to be much moderation with all humans in all industries. Everybody seems to be yes, no, left, right, up, and down when life is 50 shades of gray. But I always thought it was amazing that that general dentists are easily set to do these cases because if you got a bunch of crowding and you got a bunch of MODs amalgams and a bunch of crowns, you can take everything out of that arch and then build it back up with matrices that leave open margins and gaps, and then you put in just a simple round wire. And in 6 months, they've gone from amalgam, crooked, ugly teeth to straight, pretty, and white.
Exactly.
Fast.
In all honesty, the cases that we do, in 3 months, the improvement is just out of this world.
Okay, my job is to guesstimate what these guys or these cynics are calling you. So I know the first question they're asking is, well, how do I know that your guy's going to put the bracket on better than my guy? I mean, who's putting on your brackets? Are these, I mean, for all we know, they're no better at it than my assistant or me.
Yep. And the good thing about this is that when the brackets are put on, we have our arch wire in the brackets, and it shows you what the teeth are going to look like at the very end. So you can determine what that bracket position, the bracket that's in that position, that's what's going to happen at the very end of the treatment. And that's the key. It's driven by what is at the end of the treatment. You don't know when you put the brackets on to start off with how good they are until the teeth start to line up. What we're doing is seeing how the teeth are going to line up, and that determines the bracket positioning.
You prefer to go by Jeff or Geoffrey?
Jeff's fine.
Jeff, how sure are you? I mean, I think you guys can put them on better because you're on a model on a bench. You're not in some kid's mouth. But how sure are you, Jeff, that your bracketing system is going to put the brackets on more accurate than if the dentist did it free-handed or the orthodontist?
I hate to sound arrogant and say 100%, so I'm going to say 99.9.
Really? And you've been doing this for how many years? You've been doing this?
We've been using the digital system for the last 3 years.
And do any orthodontists use this system, or is this only general dentists?
There are some other systems that orthodontists swear by in America, okay, which are purely designed for orthodontists. And I think most orthodontists will tell you that the non-arrogant ones will tell you. What's interesting is the position of the brackets. You know how people tell you, for example, you put the bracket in the middle of the tooth, okay? That's how people have been taught. That's how you've been taught at uni. And there are case after case where you put the bracket in that middle of the tooth, but the tooth isn't still straight, and you don't know why. And we can show you why with the digital setup, because if we put it in the middle of the tooth's not straight.
So is this being CAD CAM digitally designed, or humans sitting on a bench putting these on?
CAD CAM.
It's all CAD CAM.
All CAD CAM.
Yeah, and there's no way a human eye can do better than a computer CAD CAM. I mean, so the next thing they're asking is, what does this cost?
The whole system, right? Actually, I should go back a stage, because one of the other things about this Smilefast system that we do, which I think is probably even more important than everything else, is the support. Because it's all via the web, what doctors do is every visit they put their photos on there, and I tell them what they should be doing next time, and we have a discussion about it. It's the best way to learn. So we have like a running commentary of every case that they're doing, so they get a really great learning curve. So not only with the education, the course that we teach them, and the digital indirect bonding, but we have an ongoing support system. And so that's all included in the case. So it would be about the equivalent of about $800 per case. And that includes the brackets, the arch wires, just about everything you need for that case, the elastics, the ligatures, etc., the digital indirect bonding with the 3D viewer like Invisalign, and it also includes the ongoing support from us.
Okay, there's a 25-year-old woman dentist driving her car right now, and she's saying, Geoffrey, I'm confused. Should I learn first a fixed ortho like yours, or removable? I mean, what should I learn first? Should I take an Invisalign course or a removable tray course first, or should I learn fixed? Because you're talking fixed orthodontics.
I'm doing fixed orthodontics here.
Okay, so explain to her the pros and cons of learning fixed and removable, and where should she start? Say she even wanted to learn both. Which one would be first?
The fixed would be first. And the reason being is the fixed is the most predictable, the most cost-effective way to proceed. Okay, and what the fixed will do is teach the practitioner some diagnosis, which cases to treat, which not to. One of my criticisms with Invisalign is, in fact, I was the first practitioner outside of America to do Invisalign, so I've been doing it since 1999. Invisalign believes that every case can be treated with Invisalign, which is not true. So I think from an education point of view, they should do fixed first, but I think everybody should have Invisalign in their practice, because there are patients there who just refuse to have anything else done because it is a very cosmetic appliance. And also, the fact is, Invisalign drives a lot of patients to the practice. So they have to be, I think today, an Invisalign accredited provider. So they have to do Invisalign, there's no doubt about it. But I would be doing the fixed first, because I think they'll get a much better concept of saying, Well, what cases should I do with Invisalign or not? So they'll get a much better knowledge to understand that.
I think the worst part. Oh, I'll give you a historical example to you kids who are 25, and I'll give you an example of what was going on 30 years ago before they were even born. So in endodontics, everybody says in endodontics, it's not what you put in the tooth, it's what you take out. It's the cleaning and the shaping is the success of endo. No one really cares what you obturate it with. Then Thermophil comes out. Tulsa Dental Products, Ben Johnson, general dentists who practice limited endodontics, come out with this gutta perch on a stick. And it made it so easy that general dentists quit cleaning and shaping, and as soon as they could get a file to the end, they'd warm up that gutta perch on a stick and shove it down there. Then when they would fail, everybody'd say it was a Thermophil. And blah, blah, blah. And I think the same thing is happening with short-term ortho, is that these dentists take a little bit of training and start doing ortho cases. And I am an old school. I believe you should know how to do fixed ortho first. You should learn how to do complete ortho. And a lot of these guys out there on the circuit teaching short-term ortho can't even do, they haven't even gone through a curriculum of any type of formal education on deal. And you want to do fixed first. And then I want to say something else that some dentists, sometimes I'll be sitting at a bar and these dentists say, oh, I believe you 100%. Other dentists tell me, I don't agree with this at all. I want to ask you, the reason I like fixed is because when I do removable, my patient is holding all the cards to the success. And if they don't wear the removable, then I look bad. And when I see a patient, if she's a girl and she's gone through the trouble to do her hair and put on makeup and she's got mascara and she's making herself uncomfortable by wearing, 2, 3, 4-inch pumps on her feet. And you just look at her and say, wow, I spent 3 minutes getting more. I stepped in the shower, showered, shaved, flossed, peed, got out, threw on a uniform. I was out of there in 5 minutes. She's obviously spending a half an hour to an hour. She's obviously miserable walking around in these. I believe she'll wear it, and she always does the last 20 years because she's committed to pain and suffering to look better. But god darn, when you see a 12-year-old boy laying there and he's got a burger hanging out of his nose, he's wearing the same shirt 3 days in a row, his hair's matted up, and his mom's saying, well, we want Invisalign removable choice. I'm like, look at Billy. He don't care. If he can take them out, he ain't going to wear them. And every case I've ever had that failed was some boy that took looking pretty about less serious than I do. And that's when you got to do fixed. You got to sit there and say, I don't trust Billy to cooperate. The only thing Billy's going to be compliant on is his non-compliance, okay? That's the only thing he'll be compliant on is his non-compliance. I want fixed. I want to make Billy not have to do anything in this case of work. Do you agree with that or not?
Well, totally. That's what I said to you right at the beginning, just before when you said, what about why fixed orthodontics? I said, it's predictable. And I think that's the word, it's predictable. All of the removable appliance therapy, you get some good cases, you get some disasters, and it's not predictable. And so that's why the other part to it is what you were saying before, I think is so correct. You've got to learn correct principles in anything in dentistry. With the story that you talked about in endodontics, clean the canal first. Orthodontics has principles. I can teach 90% of orthodontic principles in 2 days. And when people understand the principles, the rest of it is easy.
Why don't you put that on Dental Town?
I can do that.
I mean, we got 205,000 members.
Yep.
205,000 members. You'd be a household name in a year in 206 countries.
We can do that.
Because back in our day, we used to fly. I mean, I have flown, I can't even count how many 15-hour plane flights I've had to your city, Sydney, Melbourne, Auckland, Nepal, Hong Kong. And now you can lecture, like, that's what I love most about podcasts. I mean, usually I'd have to drive to the airport, fly 4 hours, spend the night in some hotel, get up, talk all day to 300 people, and then fly all the way back to Phoenix. Now I can sit here at my desk and talk to 7,000 dentists in 206 countries every single time. And that is just amazing. And I think that dentists have a lot of anxiety, and they can sit here and they're like, I don't know, I'm stressed, so I'm not going to make a decision. I'm paralyzed. I don't know if I should do Invisalign, fix. I don't know. But then in the comfort of their home, in their lazy boy. If they got Apple TV, they can just throw it up on their big screen, go to Dental Town Online CE, watch you for an hour, and then if they got to go to the bathroom, whatever, they can just pause it, go to the bathroom, someone calls, whatever, go through it on their own time. And then if they go through it on their own time, they'll think, yeah, okay, I'm going to give that a try. So is it any different dealing with a lab in Melbourne as it was if I'm in Phoenix dealing with a lab in LA or New York? I mean, what's the turnaround time?
The turnaround time would probably be, I'm going to say, probably about 10 to 12 business days.
10 to 12 business days. Okay. And is the $800 all up front for that one deal?
Yeah, it's approximately $800 US.
So what should the dentist be charging for this case then?
Well, that's a good question. The way we look at this is we would probably be charging, what we recommend in our course is to charge about 25% less than what orthodontists are charging for upper and lower treatment for 2 years with clear braces. Because one of the things we do with Smilefast is we want to take away the barriers of treatment. And one of the barriers sometimes is appearance. So we always use clear porcelain brackets.
So 25% less.
Yeah.
And the orthodontist would be a 2-year treatment. It was the average orthodontist 2 years.
Yes.
Okay, and how long would this, you're calling Smilefast, I mean, it's got to be faster. How long would you say the average case is?
The average case, I reckon, is about 7 months.
7 months. So 25% less, and they'll get it done in a year and 5 months less.
Yeah.
And then I want to end one thing that we're talking about money. I know I repeat myself on my podcast, but the lesson's not getting learned.
It's a very profitable procedure for the dentist.
Well, I want to say something. I want to give you an analogy because I don't believe in financing orthodontics, and I believe that the first person that realized that made hundreds of millions of dollars. His name was Lazarus out of New Orleans, a Catholic boy. He started Orthodontic Centers of America, and his genius insight that still no one understands this day is that go to an orthodontist and they say, okay, the typical ortho in the United States with the class 1 ortho, study model, x-rays, all that, it's going to be about $6,000. And then the orthodontist is going to say, okay, to do this, I'm going to need a third down. I'm going to need $1,500. So the balance is $4,500, and I'm going to finance that over the 2 years, and this is your monthly payment. And Lazarus just said, well, whoa. Your brackets were $100. Your pano and your ceph were $1. Why do you need a third down? And the orthodontist says, well, because I did all the brain, I did all the diagnosis. And I say, okay, well, let's say that you needed that. Why are you financing the back? Because it's the same thing, hair, nails, teeth, getting a mani-pedi. What if you went into the mani-pedi, and probably 90% of them around the world, at any place I've got a mani-pedi from Brazil to a cruise ship, they're always Vietnamese. And you go in there, and what would you do if the Vietnamese girl said, okay, well, you need a mani-pedi every other week for 2 years. And that's going to cost $1,000. And I need $400 down, and then we're going to have to approve you for financing and finance the back. You'd say, whoa, you're not going to have any cost until I come in to get the mani-pedi. Why am I paying finance interest on something you didn't incur? I mean, a dental office, 35% goes to the doctor, 25% to the staff, 5% to the facility, 6 to 8% supplies, 10% lab bill. You're not incurring any costs. It's not like General Motors who has to buy 30,000 parts in cash, put them, assemble a car, and when they sell you a car, say, hey, Jeff, I need 30,000 bucks. I bought a lot of shit to make that car. That's not what we're doing. We're selling a service. So Orthodontic Centers of America came out and said, hey, 0% financing, 0% interest. Nobody's denied. No credit check. $249 a month for 24 months. Everyone's approved. And all these moms said, oh my God, my orthodontist wanted a $1,500 economic barrier to entry. I don't have $1,500. My girl looks goofy. She doesn't like her smile. They ran to Orthodontic Centers of America because there was no down payment. Everybody's credits approved. The guy was a flipping genius. Now, it spun out of control and went under all this, but what was the takeaway from Orthodontic Centers of America? Less than 1% of the people never came back because, number one, they're strapped up with braces. I mean, you just can't go home and live to be 80 years old with all that stuff on your teeth. Wires come off, all that stuff like that. And So many millions of Americans were so satisfied because they didn't need a down payment. I mean, you could go in your community and say, every orthodontist in your community is saying, oh yeah, we need $1,500 down and you got to have good credit and we're going to finance the rest. And you could just tomorrow say, orthodontics in my office, we'll finance it at 0% interest, at 0% down. No credit check will be run. Everybody's approved. $249 a month for 24 months. Or this short-term ortho, you're saying what, 25% less than the general dentist. So that would be how much? So $6,000 times 0.75 would equal $4,500. Divide that by 24 equals 187. You could be out in the newspapers tomorrow saying, hey, Jeff's Orthodontics in the middle of ho-hunk down-till rural America, Kansas town dental office, we'll finance your ortho at 0% interest, 0% down, no credit check necessary. We'll do your braces for $187 a month for 24 months. And all the moms are just going to run to your office. And if you don't believe they're going to run to your office, then ask me this. Why was Orthodontic Centers of America the only company, dental services organization that ever in the history of America made it to the New York Stock Exchange and had $1 billion valuation? And you're saying you don't believe me or that I'm not right? Go Google it, man. It's already proved us all right. And nobody learned the lesson from it for America. So this $1 billion company came and went, and 120,000 general dentists, 10,000 orthodontists, and 20,000 of the other 8 specialties never ever discussed what that was all about. I mean, it was like a flipping hurricane that flew across America for 5-6 years. And it's like, as soon as it was gone, it was like, wow, what the hell was that? They don't talk about the lesson learned. And the lesson learned is you can't finance a service because you don't incur the cost of a service until you incur it. The mani-pedi shop doesn't have to pay their rent, equipment, bill, that computer, insurance on your appointment today versus your mani-pedi 2 years from now. It's completely batshit crazy, but it's cultural.
We actually have a company in Australia that does exactly what you're talking about. That they outsource it, so you outsource it, and they guarantee the money. It'd be an interesting company to get to America, because that's what we use in our practice. We have exactly that situation.
You mean it's a financing company?
Yeah. Yes. No, zero deposit, 0%, no credit checks at all.
But for ortho though, a root canal is 1 appointment, but ortho's 24 appointments. So they're very, very different breeds. So basically, so our listeners, do you think you might put a curriculum on this, or how would they learn it? Because number one, you're in Melbourne, Australia. You ever lecture in the United States, or would all my homies have to get on Qantas and fly 15 hours to Sydney?
I have lectured in the States before, and I lecture a lot in Asia as well. But I think we should really look at doing something, even if it's just a simple few hour lecture on how to diagnose orthodontic cases. A really good introduction to what's a difficult case, what's a easy case, when to use aligners, when to use a fixed appliance system. So at least get your viewers on board.
What aligner systems do you like? If someone had to pick an aligner system, which one would you like? Which one would you recommend?
I would still be talking Invisalign.
Invisalign? What about Tiff? How do you say his name? Tiff Gesh, or out of England?
The Inman aligner.
Inman aligner. And how do you say his name?
Tiff Qureshi.
Tiff what?
Qureshi.
Qureshi. That's a hard name to.
Querishi.
Shi. He's got Raven. I mean, you always hear Invisalign because they got a marketing budget bigger than the Federal Reserve.
Exactly right.
But Tiff, those Inman aligners, he's got a lot of raving fans in all around the world. So will you talk about the difference between Invisalign and Tiff's Inman aligners, or any other ones you like?
Well, the problem with the Inman aligner, it's very, very bulky. It's a very bulky product. So you can't wear the upper and lower together. It only has minimal movements on the upper 2 to 2. You can't really move anything else apart from the upper anteriors, and it's more only for labiolingual movement and a little bit of rotation. There's no extrusions at all with the Inman aligner. So it's it's ideally designed as a pre-prosthetic appliance. So you'd move the teeth a little bit, and then you'd do composite facings or porcelain veneers. Okay. Personally, in my hands, I found it very cumbersome. But we're actually looking at a new aligner product, which I think is very exciting and it's very hard to explain over a podcast, but it's an aligner with nitinol wire in the aligner. So it's like Invisalign, but it's using the nitinol wire to move the teeth.
What company is that?
That's a company in Spain.
Spain, www. You know the name of it or URL?
I can give it to you. It's Genova, Geniova.
Geniova.
Yep. And I've been over to Spain. We've been trialing it for the last 2 years, and so we're going to be probably bringing that to the market as another part of Smilefast. So in other words, if you want to do something as a pre-prosthetic alignment with very quickly in 3 or 4 months, with something which is removable, this would be fantastic. And then we've got the Smilefast for the more involved movements.
So I just went there, Geniova, and very interesting. And you think that's going to be a hit?
I think I'm just doing some more clinical trials on it at the moment. I've been with them. It's like all those products. When Invisalign first started, it wasn't good enough clinically. We had a few difficult cases. Now I went to Spain a few weeks ago and revisited it again, and we're now going to start a few more cases. I think if it works, which I can't see why it won't, it'll be a very exciting product.
Interesting. Very interesting. So you only got 2 minutes left. What's your close, buddy?
What's the close? What I believe, I think orthodontists need to change their approach to helping general dentists. I think they need to start to realise that orthodontics isn't as difficult as they think it is, and stop trying to bluff everybody. I think general dentists need to make sure that whatever course they do, they're going to be trained properly with principles, and they have a good technique behind them, and more importantly, good solid support with sound orthodontic principles. If they do that, they will never get into problems in any area of dentistry. Orthodontics should be no different to the way they think about any other area of dentistry. Make sure they find the right person to teach them and the right system to use.
And I want to end on a little macro. You said in the very beginning that you were 75% American. You went to Philadelphia. A lot of these people listening have never been to Australia. What do you see? Is practicing dentistry in Australia? That's my brother lives in Sydney, by the way. Do dentists tell Americans what it's like being a dentist in Australia, and is there any difference than in the United States? I mean, is there any more incidence of decay? Do they eat the same amount of sugar? Do you guys use community water fluoridation?
Yeah.
Are there any low-hanging fruit differences between practicing here in Australia?
I don't think so. We've had fluoridation in our city for the last 30 years, so decay is just about non-existent.
But did everyone turn communist?
Well, no, but we have a lot of communists coming to our country because we have an enormous influx of Asian dentists coming in, and so it's what was interesting. David Penn, who was lecturing with you there, who's about to meet me in about 5 minutes, I might add. David was talking about 3 years ago, we had 210 graduate dentists for Australia. Now we've got 950 per year. So the competition is getting harder and harder.
So you went from 210 new dentists a year.
Yep.
To how many?
To 950.
And how do you spell David's last name?
Penn. Penn.
Penn. Oh, Penn. Yeah. So why was there? I mean, that's basically 210 to 950. That's a 4-fold increase.
Yeah,
Why did Australia? What year did Australia start a fourfold increase in dentists?
about 2 years ago.
And that was because the Australian government started recognizing a lot of dentists from other countries.
That was part of the reason, and then because of the private universities, they set up all these private universities, and all they want to do is get money to have these students come in.
Yeah, we're the same in the United States. You have all these private schools, AT Still, Midwestern, Nova. So you have all these private universities opening up. So we've had a massive explosion of graduates too, because there's no price elasticity in the schools. That's what the schools found out. They get 5,000 applications for 50 kids, and they were charging 30,000 a year. So they said, okay, well, let's charge 40,000. They still got 5,000 applications. So now some of these schools are up to 100,000 a year, and they still get 5,000 applications for 50 to 100 seats. So that's what you call price inelasticity. Price has no effect on demand. Now, if McDonald's doubled the price of a Big Mac from $2 to $10, they'd quit selling most of their Big Macs. That's called price elasticity, where price has a very elastic effect on demand. You'll sell a hell of a lot more $10,000 cars in America than you will a $100,000 Lamborghini. And the global problem of dentistry right now around the globe, it doesn't matter if you're in India, Brazil, Australia, and America, is that 1/3 of the dental students, their dad's a dentist. Like, I have 4 boys. If one of my boys said, I want to go to dental school, and the only dental school that would let him in costs $250,000 a year, I wouldn't blink. I'd like, hell yeah, I want him to be a dentist. So there's no price elasticity on the price of education. So that's what you got to follow. So there's going to be a bigger and bigger and bigger demand, because when private money sets up a dental school, they got all the customers they can get. And my word to the wise, when these dental schools are losing money, I'm like, why are you losing money if you're charging this much for tuition and you turn down 95% of your applicants and you're losing money? I mean, does that make any sense? So what do you... So what's a dentist supposed to do? You're talking to 25-year-old kids. What's a dentist supposed to do if the future means there's going to not be one dentist for every 2,000, but there's going to be a day where there's going to be a dentist for every 1,500? So what are you going to do?
Firstly, I think the days of a specialist are going to be gone. I don't believe there's that much left in specialists. I think what the dentists have to do is become what I would call a mini specialist. They've got to be good at 3 or 4 different areas of dentistry.
And what do you think those 3 or 4 should be?
Oh, look, I think it has to always, at this stage, it has to be something in the cosmetic field, because that's where the demand is. Whether they like to do perio and implants, but they have to be in a situation where they can't refer a lot out. They have to be able to do enough work but do it well.
So cosmetics, perio, implants, what else?
If I was a general dentist, well, I would obviously throw orthodontics into the cosmetic area. Obviously, I think there'll be less and less endodontic treatment done. I don't.
Why do you think there'll be less and less endodontics? Oh, you mean endodontists or endo in general?
I think endo in general. I think people are putting in more implant when something fails.
Oh, okay. So when a root canal fails, there's going to be a lot more just extraction and implants.
Yeah.
Instead of
it's a more long-term predictable.
You're already seeing the endodontists have already telling me that you've already seen the death of the apicoectomy. Yeah. No one's going to do an apicoectomy. If they're going to lay a flap and do something, they're going to pull it. So it's killed apicoectomies.
Absolutely.
And it's really put downward pressures on retreats.
Yeah, I would say that's the 3 main areas. I think the other big area in dentistry that people need to get into today is sleep apnea.
Sleep apnea. Okay, so cosmetics, which includes ortho, perio, implants, sleep apnea.
Yep.
And what was the other one? Cosmetics, perio, implant, orthodontics, sleep apnea. Was there another one you said?
No, I think that was a...
See, I think you're wrong. I don't think you should do any of that. I think you should just remember that you can marry more money in a minute than you can earn in a lifetime. You just need to go out there and find some rich woman and just marry her. That's my final thoughts.
Howard, if you have a name of someone in Melbourne...
You mean you won't move to Phoenix to marry a rich woman?
I would move anywhere in the world to
Hey,
marry.
I want to say one thing. This is my closing words. Is I've lectured in 50 countries. I've been all around the world. I've taken my boys to more countries than they can name. And the greatest civilization society I've ever seen is Sydney, Australia. In fact,
But
it's so great. My only brother moved to Sydney, and god dang, you don't need a car. There's a restaurant on every corner. It's a walkable society, a bicycle. And what's amazing, I don't know why the whole world doesn't get it. These interstates in America, they're just jam packed. And you're the only civilization that figured out tunnels. So you need to go on the other side of town, and out of nowhere there'll just be a tunnel, and you drop down, and they built tunnels clear under Sydney, and you pop up the other side. And in all American cities, they say, well, we don't have a place for this freeway, or they're congested. Hell, the Australians, I don't know if it's because they're part kangaroo. Do kangaroos live underground? How did you guys just figure out the obvious that if you can't build a freeway here, then just dig a damn tunnel? Those cab drivers would just say, I'd say, well, how long is it going to take to get there? No problem. I'll just drop in a tunnel and pop up the other side. I mean, is that just amazing or what?
Australia is a great place to live. I have to agree with you.
Sydney's the only city where every time I go visit my brother, I just like, I don't want to go back to America. I mean, I would kill to trade places with my brother, Paul. You don't need a car. He can walk out of his house and go to any bar, restaurant, it's just so, and the people love Americans.
Oh, they do. They absolutely love Americans.
They go out of their way to tell you they like Americans, because there's a lot of countries you go to, you want to wear a Canadian jacket with a big maple leaf on the back. There's a lot of countries that do not like Americans, and we'll tell you about it. I got a free dinner in Italy because this guy started yelling at me and my son about, American policy and this and that. And the owner of the restaurant got up and kicked the old man out and then comped us for a free dinner. And I'm like, wow, that was nice that anybody can yell at me for a free dinner. It was probably going to be like a $250 tab. But Australians love Americans. You don't need a car. The weather's perfect. I mean, it's just, man. And to think it was built all by ex-convicts.
I think there's still some. I think there's still some convicts.
Is that an inappropriate joke? Is that an inappropriate joke when someone makes a joke about Australia being a prisoner's colony?
No, not at all. Not at all. But we sent them all to Tasmania, so don't worry. It's all right.
Well, hey, we're on double overtime. We're 7 minutes over. Jeff, thank you so much. I enjoyed listening to you lecture 3 times in Melbourne and Sydney and Brisbane, and I know all these Americans can't go see you lecture live in there, so I hope you have a digital learning strategy on Dental Town. I would love to turn 205,000 dentists onto your message. Thank you for all that you've done for dentistry, and most of all, thank you for being an orthodontist and talking to a little low-life general dentist like me today. That was so big of you.
No, thank you, Howard, for talking to me. Okay, it was wonderful. Well, we'll speak soon. We'll see what we can do about getting a digital onlines.
Okay, and I usually go visit my brother every year and take 2 or 3 of my sons. Next time I go down there, you want to have a coffee?
Oh, that'll be fantastic. Let us know when you're there.
But you're in Melbourne, right?
Yeah. Well, what, you should come to Melbourne. Have you been to Melbourne?
Yeah, I've been there. I've lectured there every 5 years for the last 25 years.
Well, I'll either see you in Sydney or you come to Melbourne.
Okay, buddy. Thanks for all you do.
Howard, thanks very much. Thank you.